Hello, my name is Augusto Miravalle. I am a neurologist and neuroimmunologist. I currently work in Fort Collins, Colorado. I work in a private practice called Advanced Neurology of Colorado, and I'm also a clinical associate professor of neurology at the University of Colorado in Denver. I have a passion for neuromyelitis optica during my fellowship at Harvard University in Boston. Many years ago now, I was involved with both clinical and basic science research, and I've been engaged with neuromyelitis optica since then. I am pleased today to speak on the role of AQP4 antibodies on behalf of the Sumaira Foundation for NMO. This is part of the Expert Series, and this program is made possible thanks to a patient education grant from Horizon Therapeutics. As you know, Horizon Therapeutics is committed to delivering medicine for rare, autoimmune, and severe inflammatory diseases, and also providing compassionate support from strong and simple philosophy to make a meaningful difference for patients and communities in need. So their approach to the drug discovery is aimed at providing targeted therapies for improved outcomes for the thousands of patients who have few or no therapeutic options. So let's start with the topic for today. And this is something that is usually not only important, but also could be confusing for patients to understand. And what is the role of the AQP4 antibody, so-called the NMO antibody? And just to give you some sense of historical background, in the past, we used to call neuromyelitis optica spectrum disorders Davick's disease. And perhaps you've seen that in some of the older literature. And that was in an attempt to differentiate neuromyelitis optica from a very similar disease called multiple sclerosis. What it was clear early on is that NMO patients had a clinical presentation that was very particular, that preferentially involves the optic nerves, usually both sides, the right and the left simultaneously, which is unusual for multiple sclerosis, and also preferentially involves the spinal cord. And that's why the name neuromyelitis optica was coined. And neuromyelitis pretty much means that, a disease of the nervous system that involves the eyes and the spinal cord. But it was not until the discovery of the AQP4 antibody that truly we started to understand the spectrum of disorders. And that, in a sense, facilitates our understanding of the disease process. Also facilitated the discovery of other clinical presentations or manifestations of the disease that go above and beyond the involvement of the optic nerve, meaning visual symptoms, and the spinal cord. Perhaps the most interesting discovery related to the AQP4 antibodies is the fact that these antibodies, which are actually proteins, they're molecules that the immune system responds against a water channel in the brain, right? So why do people develop these antibodies? Is because there is some miscommunication between the immune cells and these water channels in the brain. That's pretty much boils down to the basic pathology. But the presence of these antibodies not only determines the disease course, but also themselves, they drive pathology. In many disorders in medicine that are autoimmune, we often encounter antibodies. And for the most part, these antibodies are there. We don't know exactly what they do, why they're there, but they're part of the diagnostic algorithm. However, they don't necessarily cause disease. And that's an example in multiple sclerosis, right? Which we have antibodies, but we don't know what they do. In NMO, these antibodies actually are part of the disease process. Those are the antibodies that actually cause disease. The lesions in the optic nerve, the lesions in the spinal cord, the relapses in neuromyelitis optica are driven by the presence of these antibodies. So that's perhaps one of the most important learning points that I'm hoping today's audience will learn, which is not only we use the presence of these antibodies to diagnose someone with neuromyelitis optica, but also we know that these antibodies are driving the disease. So if you don't have the antibodies, perhaps there's another mechanism, perhaps there is another subset of antibodies that yet needs to be discovered. But the presence of these antibodies gives you the certainty that there is a high specificity for neuromyelitis optica. Perhaps you are familiar when you had your relapse in NMO or the clinical events that your doctors recommended, for example, plasma exchange. And what is that? Well, plasma exchange is nothing else but to try to filter these antibodies out of your system by making the blood go through this series of filters in kind of like a dialysis principle. What we are trying to do is remove the presence of these antibodies from your system. And that is key because we know that the presence of the antibodies is linked to lesions, linked to relapses, and linked to disease progression. So that's the first learning point from today, which I want to discuss, which is the presence of the antibodies drives disease. Another question that I often get in the clinic is, do all patients with neuromyelitis optica have the AQP4 antibodies? And the answer is no. We believe, based on large epidemiological studies, that 2/3 of patients with NMO are positive for AQP4 antibodies. That means 70 to 75% of the patients. But there is a group of individuals that have the clinical presentation of neuromyelitis optica that they're negative for these antibodies. And as I mentioned before, the presence of antibodies is highly specific for NMO. Regardless of the test that you use to determine the presence, whether you use a test called ELISA or you use a test called cell-based assay, the sensitivity and the specificity is going to differ, but the specificity, meaning how certain you are that the presence of these antibodies is linked to NMO, is very high as 99%. So if you have the antibodies in your blood, very likely that means that you have seropositive neuromyelitis optica. The sensitivity of the test is different, and sensitivity simply means how good is the test to pick up the antibodies, to give you a positive result if you indeed have the positive test. And that sensitivity varies depending on what tests you're using. Perhaps the highest sensitivity that we have currently available is in the so-called cell-based assay, which nearly gives you an 80% sensitivity, meaning that of 10 people that have the antibodies, this test is going to identify up to 8 out of 10, right? So in other type of tests that are available commercially called ELISA, for example, that sensitivity drops to 60%. So not everyone that has antibodies are going to be identified when using this test. So another learning point from today, it's make sure that your doctors understand, and most likely they will if they specialize in NMO or neuroimmunology, that different tests will give you different sensitivities to identify these antibodies, right? So as I mentioned before, the specificity may be the same, which is very high, 99%, but the sensitivity, which is the ability to identify the antibodies if they're present, differs. And of course, you always want to have the test that has the highest sensitivity, right? So you want to be able to identify the antibodies if indeed you have them. And that's why I personally always use cell-based assays, because those are the ones that takes a little bit longer to get the result back, but at least gives you the highest chance of identifying the antibodies if indeed the antibodies are present. Second learning point. So first one, we talked about the fact that these antibodies are present in NMO spectrum disorder, but also they're part of the disease itself, right? So not only they are there, but we know that they drive the disease. Second learning point is the test that we use to identify these antibodies varies depending on the type of test, and the sensitivity to identify them also varies depending on the test. And of course, you always want to try to get the highest sensitivity possible, which today is accomplished at a nearly 80% rate with the cell-based assays. So I want to move on to the third principle on the aquaporin-4 antibodies, which is more on the basic science behind that. What is it? So aquaporin-4 are water channels that are present in certain cells inside the brain. And there is a type of cells called the astrocytes. And the name astrocytes come from looking at the microscope and looking at the way these cells look. They look like stars. And there is a Latin term called astro, which means star. So those are cells that look like stars. And you have a nucleus of the cell, and then you have all of these legs that radiates from the nucleus like a star. And at the end of each of those prolongations of the cell, you have a foot. And that foot is going to touch the blood vessels, and it's going to be one of the first point of entry for anything that goes in and out the brain, okay? Imagine that these feet processes on the astrocytes is like the customs in the airports, right? So every time someone gets in and out of a country, they have to go through that office or that booth, right? So the feed processes of the astrocytes play a key role in many functions, in letting things in and out of the brain through what is called the blood-brain barrier. But also in the case of aquaporin-4, those are water channels. And the water channels are key in order to let water in and out of the brain in an attempt to, clean up the brain, to recycle certain parts of the cells that go through, cell death in the brain. So anytime you want to clean up your brain, you need these water channels to allow this flow of water in and out of the brain. So these aquaporin-4 channels are key, are incredibly critical. They play a critical role in the brain and the spinal cord, of course, right? So the distribution of these water channels, even though they're all present in the same type of cell, the density of the number of channels varies depending on different locations in the central nervous system. And so, of course, we have a higher density of these water channels around the areas that have, for example, more blood vessels, or around the areas that have more spinal fluid, because again, this is involved in the circulation and recirculation of water. So any location that has close contact to spinal fluid, it's going to have a higher distribution of these channels. A classic example are the ventricles, right? So the ventricles are these fluid-based spaces in the central nervous system. There is one called the fourth ventricle, that this is beyond today's talk, so you don't have to remember that, but that has a high density of these channels. And that's why lesions in NMO preferentially will affect these locations in the central nervous system. And the locations are determined by the density of these water channels. Very often patients ask me, why do the lesions affect always the same areas, right? So the optic nerve, the spinal cord, the brainstem. Well, the reason is because these antibodies that are targeting these water channels called aquaporin-4 are going to go to the areas that these channels are more prevalent, right? So they're going to go to the areas that you have a higher density of these channels. And that's why we see that preferentially NMO patients will have lesions or scars in areas that these aquaporin-4 channels are more densely present. So the third learning point for today is that the antibodies target the water channel called aquaporin-4, that water channel plays a critical role in the homeostasis of water in the brain, meaning in the recycling of water, in the transfer of molecules in and out of the brain. It's present in the on the food processes of the astrocytes, directly linked to the blood-brain barrier, the blood vessels, and the ventricles, right? So, and there is a preferential distribution of these channels throughout the central nervous system that has higher density in areas like the optic nerve, in areas like the fourth ventricle or around the fourth ventricle, the brainstem, the spinal cord. And that's why we use these locations when we diagnose NMO patients, to say, hey, these lesions are in the classic locations for neuromyelitis optica. So that was the third learning point. And please, I'm gonna stop here. I always enjoy when the conversation is interactive. So if there are any questions, please feel free to interrupt whatever way you want. You can write your questions in the chat box. If you're with someone that can help you, that's perfect. So I'll be happy to address any questions that you may have. So just to summarize what we've done so far, I always enjoy the concept of repetition in medical learning. We all learn by repetition. So apologize if I'm too repetitive, but I do believe that if you say something complex multiple times, we'll learn that better. So the first concept we talked about is the fact that the AQP4 antibodies are there in NMO, in 2/3 of NMO patients. The presence not only helps us in diagnosis, but also drives disease. The second concept is that the test that we use in clinical practice will have a different specificity, but also sensitivity to identify the presence of these antibodies. So you always want to have your doctors check the one that has the highest sensitivity, which today is a cell-based assay, nearly 80% sensitivity. The third, which is these antibodies are immunoglobulins that target these food processes. And these food processes are in cells called astrocytes, and these cells are going to play a critical role in the water homeostasis in the brain and spinal cord, and that allows for the flow of water and metabolism of water. So there's a question that I see on the chat box, which has to do with, so can NMO patients have only spinal cord attacks? Yes, as a matter of fact, the latest revision of the criteria for neuromyelitis optica in the 2015 allows to have spinal cord only lesions if you do have the presence of the antibodies. As you probably know by now, the field of neuroimmunology continues to expand. And NMO is not the only disease that causes lesions in the spinal cord. We have many other conditions that can do that. Multiple sclerosis, for example, sarcoidosis, other inflammatory disorders. There is another antibody that we recently discovered called MOG, or myelin oligodendrocyte glycoprotein antibody. And those patients don't have NMO, but they have also a similar condition where antibodies are formed, they target certain proteins, and they cause lesions. So many things can cause lesions in the spinal cord. So how do we know that the presence of spinal cord lesions suggests neuromyelitis optica? One way is by looking at the size of the lesion. So in neuromyelitis optica, those lesions tend to be large, more than 2-3 segments of the spinal cord. So something we call longitudinally extensive transverse myelitis. And these lesions, by definition, affect multiple levels of the spinal cord, could be present in the cervical region, meaning in the upper part of the neck, could be present in the mid-thoracic region, in the middle of the spinal cord, very rarely in the lumbar spine. Usually in the lumbar spine, we see other disorders, particularly MOG. But those lesions are large, are long, more than 2-3 segments long. The other characteristic of NMO lesions is that they tend to be placed in the center of the cord. So if you do a transection of the spinal cord with an MRI, the lesions in NMO are really in the middle, okay? And whereas lesions from other disorders like NMO, MS or other disorders tend to be in the lateral parts of the spinal cord. So we have few things that we look into to determine The likelihood of these spinal cord lesions being NMO. But to answer your question, yes, it could be just simply spinal cord disease. There's a second question. Have you seen patients who test negative for an extended period of time and then eventually test positive? Yes, yes, yes. So my personal record is 5 times. I had to check 5 different times in a single patient before that came back as a positive result. And why did I do that? Because clinically that patient had typical neuromyelitis optica and the result came back negative. The thought behind is a couple of things. One, as I mentioned before, the sensitivity of the test is not perfect. So sometimes you have to do it multiple times. The other thing is that the titers of the antibody fluctuate. And that was going to be my fourth point to learn today, right? Which is, okay, we know that the antibody is present, but beyond giving us a confirmation or the high specificity for NMO, can we use these antibodies to, in a sense, prognosticate or to understand the disease course over time? And the answer is yes, for the most part. And we know that the titers or the amount of antibodies is going to fluctuate. And that's why sometimes early on you may not see the antibodies, but then if you recheck, you may see the antibodies. But also this fluctuation on the titers may predict things like relapses, for example, may predict clinical attacks, may predict lesions. So we use these titers often when available to, in a sense, understand how is the disease progressing over time. Conversely, if we start medications to prevent relapses, and most of those drugs are anti-inflammatory or immune suppressants, it's possible that the titers may drop to the point that if you happen to repeat a test in someone that was originally positive for the AQP4 antibody, if that person initiates treatment with medications for NMO, it is possible that then they become seronegative. And it's not that the disease changed, it's not that they don't have NMO anymore, it's because we are using medications that is going to drop the presence of these antibodies. So you can actually have fluctuations, and it's possible that early on may be negative, then they become positive, and then they change again to negative once we start medications. Okay, that's an excellent question. Very good. So why this is important? So the presence of antibodies, we know what they target, which is these water channels. But also now recent research is explaining what happens after these antibodies bind to the water channel. And I'm giving you a sequential level of complexity on the explanation, right? So we know what the present means. We know how to measure them, what test to use. We know now what they target, which is the AQP4 channels in the food processes of the astrocytes. Now let's talk a little bit about what happens after these antibodies bind to the water channel, right? So that's ultimately what initiates this cascade of events that leads to the lesions, that leads to the relapses in neuromyelitis optica. So every time there is an antibody, whether it's a protective one, let's say someone develops COVID-19, right? So your immune system is going to create antibodies. In that case, that antibody is protective. It's intended to recognize parts of the virus and trigger an immune response to attack the virus. In the case of NMO, these antibodies are not protective. They are destructive. So it's something that happened in the immune system that led to the formation of antibodies that are not supposed to be there. And these antibodies, more importantly, they are targeting parts of your brain and central nervous system that you need. So every time this antibody is attacking or attaching to the water channels, there's going to be a cascade of events that happened that is going to try to destroy that. And what happens is that this antibody complex will initiate a cascade of things like complement activation. And that complement activation is ultimately what is going to lead to the destruction of the astrocytes. So one of the things about the immune system is that it's a very sophisticated system. It's there to help us, fight infections, for example. It's there to protect us, fight cancer. When cancer cells start to divide, the immune system recognizes that and stops. So it's a very complex system, but if something goes wrong at some point in this cascade of events, it usually takes a while for the immune system to identify that and stop it. So look at the immune system as kind of like the mix of the police, the military, the FBI, and the CIA, right? You have all of these systems that are there intended to protect in the short term, to protect more on the intelligence level. And you have different players in your immune system that has different roles. So these roles may or may not talk to each other. And the same happens with the CIA to the police, right? Or by the time they talk to each other, it's too late. So if you have an antibody that was created and that's the wrong antibody, that's going to trigger signals all over your immune system, anywhere from the local police to the FBI and the CIA. And that reaction may trigger more inflammation and more cells coming to that area and saying, we need to destroy the astrocyte. And they do that without knowing that they're causing harm, right? So that's the whole point of autoimmunity. So by the time you created that harm, the signal gets to the FBI and say, well, wait a minute, you need to stop that because we need those astrocytes. And that's when you have a secondary immune response to that to try to prevent more damage. So this is a very complex process. And now we are starting to understand what are the players and what are the stops that we can actually, in a sense, induce with medications to prevent further damage, even in the presence of these antibodies. So one of the earliest processes that happen is that when this antibody is there, it's going to stimulate the development of B cells, which are one type of immune cells. And these B cells are going to differentiate into antibody-producing plasma cells in an attempt to make more antibodies because they think that's the right thing to do. So one way that we can do that in terms of treatment with NMO is prevent the activation of B cells. And we have some medications like satralizumab, for example, that actually will block an interleukin, the IL-6, that is the one that activates the B cells to become plasmablasts, and the plasmablasts to create more immunoglobulins. So indirectly, you're preventing the development of cells that are going to perpetuate these antibodies, anti-AQP4 antibodies. We have other medications like inebilizumab or rituximab that actually go after the B cells. And by doing that, you're preventing more activation of more B cells with development of more antibodies. So you can kind of target those areas in an attempt to prevent more antibody formation. When this antibody binds to the food process of the astrocytes, it's going to, as I mentioned before, activate complement. And complement is highly destructive. This complement is ultimately what is going to lead to the destruction of the astrocyte, right? So imagine the complement activation as the last step after you activated the FBI, the CIA, everyone got the wrong signal, and they are ready to shoot that missile that is going to cause tremendous damage, right? So that last step is activation of complement. And the terminal cascade of complement, which is the last part of the complement, requires certain signals. And with a medication called eculizumab or Soliris, which is also approved, and I just mentioned the 3 medications that are FDA approved, and what you do is you prevent that last step of the complement activation that ultimately will lead to the destruction of the astrocytes. So the 3 medications that we have currently approved, in a sense, take advantage of understanding how these antibodies work and what happens after the activation of that antibody complex to try to prevent either B cell responses or more antibody production or even complement activation, and in a sense, prevent new lesions, prevent new relapses, and try to stop the disease from progressing. So I'm going to create a second pause now because I think that I shared quite a lot of information. I want to make sure that the audience have a chance to ask questions or maybe ask me to clarify certain areas. And perhaps what I can do while we wait for the questions, I'm going to share my screen and let's see, oh, I think it's disabled, or perhaps Sumaira, if you can share my slide deck that I sent before, I can use that to, in a sense, clarify some of these principles that I've been discussing before. Sometimes it's good to actually recap. And here you go. I think we can do that. But while we wait for that, so another concept is that these antibodies, the AQP4 antibodies, in a sense, when they were discovered in humans and then studied in mice or in animals, like many things happen in medicine. And that helped us understand one principle, which is you can passively transfer the antibodies from animal to animal and induce lesions that very much resemble animal lesions. So that is allowing us to understand that these antibodies not only are there to cause disease, but also you can transfer these antibodies to animal and mimic animal lesions or animal-like lesions. So this slide, I find it helpful to kind of like put that into a visual, and apologize for those individuals who perhaps have visual impairment. And you know, I will explain it too as well, but if you don't, perhaps you can appreciate the fact that here you have an astrocyte, which is the cell, and you have the presence of these AQP4 antibodies that targets the water channel here in light blue. And that's going to stimulate these plasmablasts, which come from the B cells. And these plasmablasts are going to create more antibodies, which are here in red. These antibodies are going to circulate, go to the brain, and then try to target this water complex. After that happens, you activate complement. So in a sense, here in one slide, you have the three areas that the currently approved medications for NMO affect this antibody formation. With satralizumab, which is an anti-IL-6, what you do is you prevent the activation of plasmablast by blocking the interleukin-6 antibody receptor, and then that results in a radically lower production of AQP4 antibodies. With inebilizumab, which is an anti-CD19 antibody, what you're doing is you're affecting that B cell response, right? Anywhere from the pre-B cells to the antibody-producing plasmablast, that they carry that, that receptor in the membrane. What you do is you pretty much bind to those and you prevent these cells from circulating. You destroy actually the cells that you have, in a sense, indirectly decreasing the number of antibody production. With Soliris, which is eculizumab, it's an anti-complement medication. What you do is you prevent pretty much the last step of the cascade, which is complement activation and destruction of the astrocyte. So understanding the science helps us also understand, in a sense, the areas that we can actually target therapies and prevent further damage in neuromyelitis optica. This is a little bit more detailed, but what I want to show you here is, again, the three medications that we have currently today. And I know that in the Sumaira Foundation website, there's a wonderful chart that lists all the different medications that are approved, along with you know, the route of administration. There are two that are intravenous, one that is subcutaneous. Also list the frequency of the administration, most common side effects, and so on and so forth. So if you're not familiar with that, I encourage you to go to the Sumaira Foundation website and actually check for that chart that is extremely helpful. But most importantly, what I thought to talk moving forward is, now that we know the presence of these antibodies drive disease, and we use it for diagnostic purposes, perhaps for prognostic purposes, we know a little bit about the science on neuromyelitis optica and what happened with the different players in your immune system. We have now 3 approved medications for NMO. How do we, as providers, as healthcare providers with our patients, how do we go about, choosing the different therapies in neuromyelitis optica, and understanding that the science is there, but science is nothing unless we can understand how to apply that to our patients and help our patients, right? That's the ultimate goal here. So of course, we look at things like efficacy of the medication, which has to do with, how good they are to prevent relapses and lesions. And we usually use data from clinical trials to understand that. But the caveat is, we learned that certain medications work well in this group of patients, but we don't know whether that's going to be good for you until we try it, right? So I personally take this data from clinical trials very seriously, and I'm glad we have the studies because it gives us a lot of information. But we never know if this drug is going to work for a given patient until we actually try it. So we always look at the risk and side effect profile. Like any intervention in medicine, you need to be familiar with what are the potential risks and what are the benefits, but also the risks. What are the side effects, which may or may not be the same as a risk, right? So risk meaning what are the negative consequences to your health that this intervention can pose. Side effects means, well, you can take, medication that may give you maybe a rash, but that's transient and that goes away. That may or may not be a risk for you. So we always discuss both of them. But we also look at more of the access concept, right? So what is the cost? Do you need infusions? Do you need subcutaneous injections? Do you have access to an infusion center? Some patients are with NMO are disabled and they can't move to be able to go to an infusion center. They have visual impairment and they prefer to stay home. So in those cases, perhaps a subcutaneous form may be more optimal for those individuals. We also look at comorbidities. Do you have other medical conditions that perhaps are of importance that we need to pay attention to? And of course, drug and drug interactions and whether the medications you're taking and so on and so forth. So that's just one slide about the way we go about the selection of different therapies. So there's a question here about anti-B cell therapies and response to vaccine from Karen. Karen, this is an excellent question and very timely. So let's talk about COVID-19 vaccines for a minute. So as you know, there are many vaccines that are available. Many of those have different mechanism of action. Some are messenger RNA vaccine, like in the case of Pfizer and Moderna. Some are DNA vaccine. What that means is that the vaccine itself has only a portion of the virus, not the entire virus. But that portion of the virus is intended to, after being inoculated in patients, after being introduced into your body, it's going to lead to an autoimmune response that will train your cells in your body to be ready to fight anything that looks like that, right? So what you're doing is you're training your own immune system to be prepared, that in the case you're exposed to this COVID-19 particle in the future, you're ready. You have an entire army of cells that are ready to respond to the virus. That response occurs in 2 compartments of the immune system. One is what we call the cells, or the cellular immune response. For that, you need to have your T cells, you need to have your B cells, and both groups have different roles. The other way to protect against vaccines is with antibody production, with immunoglobulins, right? And those immunoglobulins depend directly from B cells and plasma cells. So the question has to do, if I deplete the number of B cells that an individual has, am I going to create a blunt response to the vaccine? Are patients going to have enough of a response that will allow them to mount a protective response should they get exposed to COVID-19 in the future? And that is an excellent question. So let me tell you what we know. In terms of neuromyelitis optica, the studies have been very limited due to the number of patients not being as high as what we have in other conditions. But we do have quite a lot of data coming from MS patients that are receiving anti-B cell therapies. Perhaps the most common is ocrelizumab, which is a humanized anti-CD20 molecule that goes after B cells. What we are learning is that patients on ocrelizumab in MS, they do have a decreased response to the COVID-19 vaccines when you're measuring the antibody production. So if you just simply measure that second portion of the response to the vaccine, which is the antibody production, most patients, not all, but most patients on ocrelizumab, they have decreased number of antibodies. We don't know yet if that translates to a higher risk of symptoms or infection should these people get exposed to COVID-19 in the future. We don't know that piece, but we do know that the number of antibodies is decreased, and that's not surprising, right? So that's how the medication works. You work and you get the effect by decreasing B cells. Indirectly, you're going to have decreased antibody production. What we are trying to learn now is how about the T cells, the other side of the spectrum, right? So as I mentioned before, you mount responses to vaccine through cell and antibodies. So the B cells, we know that are decreases, the antibodies, we know that they are decreased. How about the T cells? And those T cells play a critical role in response to vaccine. That piece we don't know yet. So I know that there are many studies looking into what is the T cell response to COVID-19 vaccine in patients on anti-B cell therapies. And hopefully we'll learn that soon. I will say that in a given patient, I've been a strong advocate for vaccination. I think vaccination, in a sense, it not only from a public health standpoint is the right thing to do, but also in an individual patient is everything we can do to prevent actually patients from getting symptoms. So even if you worry that you may get a blunt response, I think still that's better than no response. So I will say, even if you are on a B cell therapy, still get vaccinations unless you have contraindications for it. There are ways we can measure antibodies. So talk to your primary care physician or neurologist and see if we can measure the titers, and that gives you a little bit of information. Please don't assume that if you don't have antibodies, you're not protected. However, I always say to my patients, particularly those in immunosuppressants, wear a mask, stay with social distancing, wash your hands. Just even if the local authorities tells you that it's okay to not wear a mask, I think because you're immune suppressed and you may have a blunt response, take an extra level of precaution, right? So I think we are not out of this pandemic yet. As you know, there are now different strains of the virus that are being developed. So I think it's the right thing to do to also be responsible about it and continue to minimize your chances of getting infected. So I think that addressed the last question. And I will see if there are any other questions here in the chat box. Oh yeah, I was missing those ones, so sorry for that. So complement levels as markers for a relapse. That is a great question. And so, yeah, you can measure the complement levels. Certainly by the time complement is activated, it's actually right there by the time you're having destruction. So you could theoretically do, but it's usually very much at the time of the relapse. With the AQP4 titers, you can predict relapses with titers if you can measure them. So in a sense, that will give you a higher chance of actually using that in a meaningful way. Donna is asking, is there any work researching Will there be a way to repair or reverse the damage to relieve some of the damage along painful symptoms? That's a great question, Donna. Yes, there are many drugs that are being studied, particularly in the field of multiple sclerosis, that are looking at remyelination and repair. The thing with NMO that is different to MS is that, unfortunately, demyelination and damage occurs by destruction of cells. And cells in the brain, we are not good at regenerating cells, right? So we may be good at creating new myelin in the future. There are many promising products there, but once a cell is dead, the cell is dead. And that's why in NMO, the relapses are so devastating. That's why patients often have so much disability that come out of a relapse, because once a cell is dead, we are not good at replenishing number of cells like astrocytes. So that's why an NMO is so critical, that we do everything we can to prevent relapses. And I'm more on the line now that we have more approved therapies. I tend to find myself recommending highly effective therapies earlier, not waiting until patients accumulate relapses, because we know that the chances of recovery are very minimal. So my first, Sonia is asking, my first antibody count for NMO was 413, was significant. So we do know that higher titers have been linked with higher chances of relapses. If the titers were measured in the context of an acute relapse, perhaps that's the reason. But again, I will be more inclined to say, hey, if you do have these higher titers, if you had relapses, let's just go to highly effective therapies, because everything you can do to prevent relapses is only going to help you, okay? That's an excellent question, Sonia. So Connie, if one is stable on the non-approved medications, no relapse, tolerable side effects, maybe 7 years, why would you switch to one of the 3 approved medications? Great question, Connie. Let's forget about NMO for a minute. Let's talk about medicine. There is a principle in medicines that says, don't fix what ain't broken, right? So meaning, if things are fine, don't fix it, because there is a reason why you're fine. So that principle I always try to keep in mind, right? So if you're on something that keeps you stable, you don't have side effects, you're fine, good. And that's happening now. We've been using medications that are non-FDA approved for decades, and it's hard to change to something approved if you don't have a reason for it. But it truly depends on where you are, what your history with NMO was. The only situation in which I will maybe suggest to change, even if patients are stable, is if your NMO has been very active early on, if you have a high level of disability and you're on a medication that is not that effective, like example being, for example, Imuran or methotrexate, those oral medications that actually don't have a lot of efficacy, and I will say, do you really want to stay here? You know, we have better options now. That will be the only scenario that I can think of. But if you are, let's say, on rituximab that has a high efficacy and you've been stable on that, I would probably say, let's just stay on it. Let's see how things go. Let's maybe measure antibodies frequently. Let's make sure that we stay on top of any new symptoms. And of course, if we do have evidence of breakthrough disease, then let's be very aggressive in what we choose next. All right, I believe I answered that, that question already for Sonia. There is a question about, Mary is asking, patient, what is the big difference between Enspryng and Actemra? So again, we were just talking about that, right? So the different, in between the different medications, they work at different levels. We have medications that work on the IL-6 receptor. We have medications that work on the anti-CD19 receptor, and we have medications that work on the complement. In terms of clinical efficacy, the 3 medications are actually very comparable. What I'm going to do is actually give you this opportunity to share with you this chart that I was referring to before that gives you a visual kind of comparison between different options. Let me just share my screen again. And so you can see here the different options that you have with some data on pharmacology, in the infusion methods or drug delivery methods, frequency. And so you can get a little bit of a sense of what are the difference. In terms of clinical efficacy, as I mentioned before, you have the data from the clinical trials, but don't get too hung up on a 2-point difference on the percentage, because as I mentioned before, what matters is, how is that medication working for you? So efficacy is one of the factors that we choose, but it's not the only factor that we choose. We pay attention to when looking at the right medication for a patient. But this hopefully helps you to get a sense of, how do they compare, at least with the data that we have available. So Lavon is asking about biosimilars for Rituxan. Yes, that's a great question too. There are many now biosimilars that are being developed. We always are a little bit careful with the use of generics, or in this case, biosimilars. However, because the molecule is such simple molecule, it's just an antibody against anti-CD20. For the most part, these biosimilars are going to be offering a very comparable efficacy and safety profile. So it actually comes down to price. And most insurance companies are looking into that, and some will actually require that you use a biosimilar before. And unfortunately, that's a reality we live. I prefer a biosimilar over no options. So in some cases, I agree to use the biosimilars, not because it's my first choice. I always try to prefer the FDA-approved, commercially available medications, just because we have more data that supports the efficacy and their use. But sometimes we are restricted by insurance companies. And if that's the case, I still prefer a biosimilar over no treatment. So I have cases in which I agreed to use that. All right, so I believe we are getting to the hour here. So I would like to wrap things up here. And first of all, thank you to Sumaira Foundation for allowing me to participate in today's talk. I'm a big fan of the foundation, everything you do for our patients. So thank you for that. And also thank you for the audience for your questions and for the time that you spent today with me.